you know, Ironman's kind of a fairly selfish sport. There's a lot of time that you have to spend by yourself trying to train. And the best way I can offset that is by getting up really early, getting workouts in before the kids wake up after they go to bed. The nice things for me is that my wife Shannon actually does all of this just like I do. So a lot of mornings when I'm getting up, she's getting up with me. When I'm staying up late getting workouts in, she's usually up with those as well. And our dates tend to be workouts. We'll get a babysitter to go to the pool, or we'll get a babysitter so that we can ride our bikes together. And I think that's really kind of strengthened us as a whole, because we really are kind of working out as a family. And then when you realize a lot of these times when I go to the races, she's in the same race I am, so we're experiencing a lot of the same emotions, a lot of the same nervousness. And I think we really kind of understand what each other's going through. I think that's really helped us in the long run.
Where have these trips taken you so far? I've seen some of these trips.
So, aside from some like weekend trips to say Texas or Florida, we have gone to Cozumel, Mexico, Kailua Kona, Hawaii. I've been to Washington State. She's been to Canada. Haven't really ventured too much farther away, but probably once our kids get a little older, we'll start maybe trying some further, or races further away, like in Europe or somewhere.
Okay, so let's see. I'll make sure I got everything. Because the number counting wasn't quite matching up with everything. So give me an idea. We're going to go through that thing. Give me an idea of your workout schedule.
Okay. I get up pretty early. Most days I'm up at 4 or 4:15. I get in a pretty decent workout in the morning. I finish by 6 a.m. just before my kids wake up. Go to work throughout the day. Usually leave at about 5:30, 6 o'clock. Spend a couple hours with the kids, and then once they go to bed, it's usually another hour, hour and a half in the late evening before I go to bed.
All right, so what time did you get up today? What time is it now, and how long have you been going at it?
I got up today at 4 a.m. It's now 5:30. I've been on the bike an hour 15.
All right.
You asked me to define what ironcology is.
Yeah.
Okay. So ironcology is a concept I came up with a couple years ago, where what I was trying to do is combine my hobby, which is racing Ironman triathlons, with fundraising for the Markey Cancer Center, or specifically trying to improve some of the treatments I provide, and I work as an oncologist. So I just combined them, so ironcology was that blend. We've been fairly successful. In 2014, my first race was Ironman Louisville, where I raced as the final starter and raised money per person that I passed. In the first race, I raised $54,000. Our original goal, honestly, was pretty modest, just 15 or 20. I think the long-term goal, we thought we could maybe raise 50,000. But for the end of that year, I had ended up raising 141,000. And as we keep going, I've now raised about $250,000, all of which goes to the Markey Cancer Foundation, primarily devoted to patient care.
All right, so tell us some of the things that this goes towards in terms of equipment, towards care.
So the very first project that I fundraised for was trying to build a whole new radiation therapy treatment suite. That would be kind of a combined treatment room, primarily allowing us to perform really complex radiation implants. That project has already been approved by the UK Capital Committee, and we're actually in the design phase right now. But about $200,000 of the money from what I raised is going to that project. The remaining money we've honestly been trying to fill into a kind of a bucket, so to say, trying to make it available for some of the clinical trials that we want to open up to make new treatments available for patients, but ones that they need funding. So some of the investigator-initiated trials, or some of the trials that are written by some of the doctors here in Kentucky that, in order to be offered to patients, need backing. We're trying to shuffle that money towards them.
So, let's see, one more. Oh, so tell me about some of the trends you're seeing. You're on the
I think one of the things that's really happened over the past 10 years is there's been a very big shift in what's the goals of clinical trials. You know, if you ask patients, what's the one thing you want to hear in a clinical trial or a treatment that's going to benefit you the most? And everyone's going to say the same thing: they want a cure. But the reality is cancer is an extremely complex disease. And sometimes actually discovering a treatment that's going to lead to a cure, it's a lot easier said than done. So one of the things that I think has really shifted is this idea of what treatments are we going to have that's really going to promote a better quality of life, or what's going to delay the inevitable, maybe extend life but not necessarily save it. Now that's really come under fire probably in the past year or two, because a lot of the people at the NIH and the National Cancer Institute have realized we're not really finding treatments right now that are cures, so to say. They're more temporizers or prolong the inevitable. So the current trend with cancer treatment, at least, is really starting to explore immunotherapy. Or if we can't necessarily find a cure with the chemotherapy agents, or is there no such thing as a right chemo combination, is trying to look at, well, what can we do to enable the body itself to start fighting cancer? So a lot of the newer treatments that I think we're going to be seeing very soon, maybe even as early as in the next 2 to 3 years, are going to be focusing on activating the immune response to actually start fighting the cancer, so that maybe in that situation, when we go back and we use our conventional chemo drugs, some of our surgeries and radiation will actually have a higher chance of curing these patients.
Now, some interesting stories. So, you work at Marquis Cancer Center, but that's not all you've treated. You've been involved with, here in Central Kentucky, with some of the equine care.
Yeah.
Tell us about that experience. How did that happen?
So, obviously where I've done a lot with radiation implants and trying to advance treatments, I guess I've got my name out a little bit about some of the things that I can offer. And I perform some of the most of a very special kind of radiation implant. It's called permanent planar implants, where you put seeds of radiation directly into tumors. So I randomly got a phone call one day from one of the veterinarians at Rood and Riddle, who asked me if I'd be willing to come evaluate a horse. So the first horse I saw had an orbital tumor kind of right around its eyelid that, from a human cancer perspective, it was a chip shot. I mean, it was an easy one. But the problem with the poor horse was the tumor had retracted its eyelid all the way back to where it couldn't blink. The owner was having to put drops in it every day. So we kind of conceived the idea of doing it. Now, to get radioactive sources delivered anywhere other than a major radiation facility is a huge hurdle. So for me to perform that implant actually took about probably 2 months of working through the state, going through the Nuclear Regulatory Commission, getting myself listed as a registered user for radioactive sources at the horse farm. Now, all in the end, it ended up working, but it was a pretty different experience when they wheel in a 2-ton horse for you to start operating on. But the nice thing was that implant worked. The downside to it was animals aren't quite as predictive as humans. You know, I can do a procedure to a human and say, don't touch it, don't mess with it. But you can't really tell a horse that. So honestly, the horse did well for about 2 weeks, and then it rubbed its whole side of its face against the barn door. The whole thing got raw, and then it got infected, and it took about 2 months for it to heal. But now it has, and the horse looks good. The horse is out competing again, so that was a pretty big learning experience, kind of as a whole facility's point of view, and how to actually integrate yourself into a new hospital when you're not on staff. And then I got invited back to do a second one a few months ago. Now that one was a lot more challenging because I had to do a radiation implant inside of the horse's bladder. But the surgeon that was at Rood and Riddle brought the scopes in, and we kind of did it as a joint case, and I think it went fairly well.
Yeah, that's impressive. All right, let me get some. All right, I assume you're ready.
Okay, sure.
All right, you got me. So tell me, where are we right now?
Right now we're in the ground floor of the Markey Cancer Center Roach building. This is one of our treatment units, or a linear accelerator that we primarily use for treating pretty much any head and neck, lung, prostate, pretty much any main type of cancer that is a standard treatment we use on this unit.
So what goes into having somebody ready for treatment? We were talking about it just a minute ago with the tattoos and that sort of thing.
Right.
What goes into getting people ready for this?
You know, obviously the first step in getting someone ready for a radiation treatment begins with meeting the person, doing a physical exam, reviewing all the relevant imaging and some of their path reports. Now the hard part is a lot of times we have to take that patient and get a digital copy of their body contours into our planning system. So the next step usually involves us doing a CAT scan where basically their CT units are uploaded into our computer programming software. And then it goes through a process where myself, a radiation oncologist, will contour the areas that we want to treat based on a CT scan. We're identifying the radiographic changes, but then we're also kind of enlarging our volumes or shrinking our volumes based on the physical exams that we've performed. And then we have an additional person called a dosimetrist that will actually begin creating a radiation plan targeting the areas that we want to treat. A physicist will then double check the entire treatment, and what that ends up with is a digital treatment plan that gets transferred to one of our linear accelerators. Basically this is a file that has a total amount of time and a total amount of dose of radiation that's going to be delivered. And then they start to get pretty complex after that in terms of, are we treating the machine in a static beam? Are we using some type of rotational therapy? Are we going to include the lead-lined leaves that are inside the machine coming in or coming out, blocking portions of the treatment plan? So it's usually about a 3 to 4 day process at least from meeting the patient to having them ready to receive a treatment here in the treatment vault. Do I need to do that again?
No. So I actually checked the audio before.
Okay.
We're gonna. So tell us, how does this, a machine like this one, treat cancer?
Okay. So if you can kind of hear the humming right now, it's behind the wall. The way this machine works is it actually creates what's called basically photomagnetic radiation or photoelectric radiation. But what's happening is the transformers behind the wall are taking up electric current. So just the direct current that you would otherwise activate a TV with. The transformers step it all the way up to several million volts. Has a very high electricity and strength. It accelerates electrons to the speed of light inside this unit, and then it rams it into a little tungsten target. And that exact process of speeding a charged particle up to the speed of light and ramming it into a target that has a high melting point generates radiation. So these machines generate specifically what's called photons when we have that particle, or when we have the tungsten target in, or if we remove the tungsten target, it comes out as electrons. Now, how about if I step back and I'll break that down a little bit more? So I'm saying, I'm thinking that's probably still a little bit too advanced. All right. So if you hear the humming behind the wall, those are actually the transformers as well as the cooling system for this unit. Basically what it does is it takes the electric current out of the wall, the same electrical outlet that you would use to power a TV, and it uses it to, in a long roundabout process, to create its own radiation by raising that electric current very high to several million volts and then converting that into radiation. This is something that you cannot see, smell, hear, feel, or taste. The machine's not on because the meters are off right now and the doors are open, but even when the patient's in here, they actually have no sounds or any real noticeable changes that the radiation's on. But fundamentally what it does is the radiation enters kind of in a focal pathway, just like a laser beam would be if you had a laser pointer. It enters that part of the body and it's able to interact with water, and in the process of interacting with water, it actually generates free radicals that tends to damage the cells in its pathway. Now, one of the unique things that allows radiation to be very effective at treating cancer is that most of the damage that happens from radiation to our normal cells, they're able to repair it. Whereas most of the damage that's caused to cancer cells, they're not able to repair the majority of that damage. So inevitably you start getting preferential killing of cancer cells compared to your normal tissue. So
So how do you ensure that it's targeting cancer cells and not the tissue that it's going through to get there?
Okay, so you can't 100% only target the cancer and remove the tissue that's next to it, okay? The original ways of doing radiation was primarily what we called two-dimensional, whereas kind of you treated the whole plane through a person and it was only fixed beam arrangements. So this unit's kind of analogous to a fluoroscopy unit. You can rotate it into position, it parks, and it delivers a beam. Now, some of the more advanced treatment techniques that have been developed over the past 10 to 15 years rely on something that's called intensity modulated radiation. So yes, we still move the machine and park it in a certain position, but we're changing the intensity while the lead blocks in the head of the machine are coming in or coming out. What this allows us to do is kind of produce different intensities from different angles that create a composite treatment plan. So for example, if you want to treat a tumor that's next to, like my hand, and avoid something that's next to it, well, you use all of these beam angles and not the ones that would otherwise pass through what you're trying to avoid, or the opposite way. And by dividing a treatment up into, say, 15 different beam angles instead of 2, we're actually able to relatively spare normal structures that are adjacent to a cancer.
So what are the things that people will experience in terms of symptoms, potential symptoms after a run of treatments?
Right, so one of the most important things to realize whenever you're talking about radiation treatments and side effects is where is the treatment being directed. I think everybody has some form of a horror story, and a friend or a colleague who, the ones that tend to come across are people who have tonsil or throat cancers, people who have low pelvic cancers, where they have a lot of side effects. But again, it completely depends on where we're treating. Most of the side effects from radiation you can boil down to what's going to happen during treatment and what's going to happen after treatment. Pretty much all the side effects during treatment are going to boil down to some form of a sunburn. It's easy to see the sunburn when it's on the outside of the body on the skin, but you realize that same thing's happening on the inside. So when we treat someone with a throat cancer, sunburn on the outside, they'll probably have a sunburn on the inside. It's going to be on the inside of their throat, inside of their mouth, down their neck. So what they'll feel is some degree of pain, probably some trouble swallowing. It'll feel like they have a really bad cold. And then the other types of things we see is you tend to see a lot of dry mouth that goes along with these treatments. Now, if you compare that to, say, a woman having breast cancer, she'll probably experience a sunburn on her breast. Someone being treated to their abdomen, again, maybe some skin changes, but primarily they're going to have side effects related to a sunburn on the inside. So the bowels will be, a little irritated. They may have some diarrhea. The bladder is going to feel irritated as well. They may have some burning when they urinate or feel like they need to urinate more often. We also will tend to see hair loss, but that's only when we're really treating hair-bearing areas. And then the larger side effects that we tend to worry about more so are going to be your later side effects, which are more scarring related. So, 6 months down the road, we may see people actually develop a lot of scarring that, if it's in the head and neck, it impairs their ability to swallow in terms of coordinating all the muscle actions. In their abdomen, again, we can start to see patients develop small bowel obstructions, fistulas. There can be some significant side effects such as that we tend to see late.
And one of the things people relate with this sort of thing, or I don't know if we got a mask that doesn't have a name on it or one that won't show it, but you see a lot with the masks, and you've actually done some work with those in the past. What is the purpose of the mask that people use during the...
I'll grab one, and... It does, but I'll cover it.
Okay.
Is that all right?
Perfect.
Okay. So this is one of the radiation masks that we commonly use. Okay. The masks serve several different purposes. Number one, all of our machines, if you back up, have these lasers, which is how we actually line up all the patients for treatment. The purpose of the lasers is that every day we have a consistent setup. No matter if they lose weight, if they shave, we should still be able to identify those lasers because they're based on a tattoo that we give the patients. Now, if you're in the head and neck, you don't want to tattoo their face. So A, the masks serve as positioning by we mark the laser points on their mask. The second thing that the mask does is obviously there's a lot of very important structures in and around the head and neck, especially in the brain. So if we've created radiation beams that are treating a tumor and completely avoiding those sensitive structures, you want to know that once we position the patient that they're not going to move and turn their head and suddenly our treatment plan is not delivering what you think it did. Now, here's an example of a mask. You can kind of basically collapse it and it springs right back. So the whole idea is that for any relative person that comes in, mask isn't going to fit. But when you put the one patient the mask is based off of, it should fit like a glove, and for the most part it's not that uncomfortable or painful for them. Now I will admit this can create quite a threat for people who are claustrophobic, or some people who maybe have, say, an ulcer or something on their face that makes it very uncomfortable. So for example, this patient had a little bit of trouble around the nose. You know, we can cut the nose out. Sometimes for some of the children that I treat, we'll cut the eyes out, try to make it look like a superhero mask. We'll try to do little things like that to try to make it a little bit more comfortable for them. But inevitably, you know, we have to have some form of immobilization so that we know we're actually delivering the treatment that we proposed and created on the computer.
All right, so what does Ironcology mean for the Marquis Cancer Center?
So I think before I kind of became or created my whole Ironcology, I think before I created my entire Ironcology campaign, there wasn't a very big presence of physicians becoming involved in fundraising. So indirectly, I've kind of opened the door, I think, for physician engagement as well as requesting help from the patients that we actually treat. You know, one of the most unique things that Ironcology created, or at least brought to light here, was this concept of crowdfunding, and that it really is a very successful method of gathering donations. You know, the original idea I had with Ironcology was just to raise a little bit of money that I could then go to some very large potential donors and ask for large amounts. When in turn what ended up happening was I raised all the money I did off of small donations and everybody giving a little bit. So instead of 5 donors who were going to donate $25,000, I had 500 donors who all donated $50, and it seemed to work out. I think moving forward, this is just another platform that we have here at University of Kentucky that's a little bit unique, that makes our cancer center stand out, that seems like it is capable, at least so far, of supplementing some of the much needed research dollars and fundraising dollars that we need in order to provide good cancer care.
So we're going to switch out. I'm Dr. Ryan Stanton here at the Marquis Cancer Center, and this may be the middle of the day and Dr. Fedek looks very professional, ready to treat his patients, but the day started much earlier. It started about 4:15 this morning when he got up to get in shape for Ironcology. The workday here at the Marquis Cancer The workday here at the Marquis Cancer Center is very busy. Patients in and out throughout the day getting their much needed cancer treatment. But Dr. Fedek's day started much earlier. In fact, 4:15 this morning. I joined him this morning for part of his workout. Of course, I didn't work out at all. Ironcology brings together a great mix of medicine and desire to help patients through an interest in exercise. Dr. Jonathan Fedek and his wife Shannon work tirelessly for their patients to help them get better, feel better, in advanced cancer treatment. I'm Dr. Ryan Stanton, and this has been a Tools of the Trade. Sound all right? Let's make sure our timing, our microphone is working. Yep. I'm Dr. Ryan Stanton, and this room may seem quiet now. Let's get rid of my sunglasses. I'm Dr. Ryan Stanton for Tools of the Trade. Today I joined Dr. Jonathan Fedek. This may not look like a typical doctor's office, but this is his office when it comes to training, raising money to save the lives and improve the lives of his patients. I'm Dr. Ryan Stanton, and I'm up early this morning. How early, you may say? Let's try 4 a.m. 4 a.m. here in the training room of a local physician who's trying to raise money to help his patients to improve cancer care in Central Kentucky. So cancer care may take more than just a medical degree and a board certification.
It takes grit, commitment, and working hard to do what's necessary to raise the money and do the things your patients need to be healthier, safer, and live longer. I'm Dr. Ryan Stanton, and this has been a Tools of the Trade. I'm here at the home of Dr. Jonathan Fedek and his wife Shannon, both physicians who work hard for their patients. But unlike the typical physician's office, this here is a room full of bicycles, awards, photographs. Oh, shoot. I'm Dr. Ryan Stanton, here in the home of Dr. Jonathan and Shannon Fedek, both physicians working hard to help the health and, oh, shoot. I'm Dr. Ryan Stanton, here in the home of Dr. Jonathan and Shannon Fedek, two physicians who work hard to help their patients. But this room's a little bit different, not a typical physician's office. This is a room where they train to get in better shape, to be prepared for the races they're taking on to improve the health and safety of their patients. I'm Dr. Ryan Stanton, and it may seem early, and it is. It's about 4 a.m., and here in a few minutes, It may seem early, and it is. It's about 4 a.m., and here in just a few minutes, Dr. Jonathan Fedek is going to take oh, shoot. It's very early, about 4 a.m., and here in a few minutes, Dr. Jonathan Fedek is going to saddle up on one of these bikes right here to start his morning training. Not unusual for him, something that he does about 6 days a week. It's about 4 a.m., and here in a few minutes, Dr. Jonathan Fedek is going to saddle up on this bike right here and start his training day. A day like most others, 6 days a week, getting up early, staying up late, training hard for the health of his patients. Boo! Shakalaka.